what's out there in the marketplace. So we want to make sure that everything up here is as up to date as possible. So off we go, uncovering solutions to Massachusetts healthcare crisis. So for better or for worse, we've seen a lot of information about it in the news, and we're going to dig into all that today. I think most people on here know us, but just for quickly for anyone on here who doesn't know us, so we're Apex Benefits Partners. My name is Jeff Bastian. This is our team here, John, Kelly, and Don. I believe they're all on the call here as well. But our company just rolled over to 7 months old, so things are going well. We appreciate all the support of all of our clients and all of our business partners. But we are a full service insurance agency. We're going to talk a lot about some of these things today that you see on here. So obviously healthcare, we're going to talk about some specialized programs. We're going to hit on technology a smidge at the end. But wellness and nutrition, we have a big announcement around that. And then just some of the other services that we bring to the table for our clients. So healthcare, we're going to start. We know it's been in the local news, but it's also been in the national news. So this is all in the last 90 days. So President Trump has had 2 executive orders surrounding healthcare. The first one came back in February, and it was about the actual release of prices from healthcare systems. So anyone who's used these type of services within our current carriers, I'm going to focus mostly on Blue Cross Blue Shield and Point 32 Health. Mass General Brigham's out there as well. We're going to talk about our Cigna program, but those are our 2 main carriers right now, which is Blue Cross Blue Shield and Point 32 Health. They do have price transparency tools within their platforms for members. My guess is not a lot of members use them, but they are there. So the first executive order is really trying to make sure that members receiving care understand what they're paying for their services. And we're going to go through an example later on where one of our self-funded clients, and for those clients that are self-funded, you get access to that information pretty readily. And that's part of the benefit of looking at self-funding. Now, our reality in Massachusetts is most groups don't self-fund, so we don't necessarily have access to all of that data. But the goal of that first executive order is to try to bring some of that to light. The one that just happened, and this is again, this is May 12th. We have I have 2 updates in this deck from the last 48 hours. So May 12th, the executive order on drug pricing. And we're specifically going to talk about GLP-1s today, but this isn't exclusive to GLP-1s. We've seen some major updates to prescriptions, and anyone who's had a little bit deeper dive within their health insurance programs knows that prescriptions drive a lot of your cost and they're extremely expensive. And so for those members that have looked to source drugs elsewhere, Canada has been one, Australia, there are places across the Atlantic Ocean that we source our prescriptions from. For some reason, we can get them really less expensive everywhere but our manufacturers here in the United States. And so right now, there's this power struggle between the president and pharmaceutical companies. So I don't know if anyone's been watching the news, but the pharmaceutical companies are pointing the finger back at the president. The president's pointing the finger at him. Everyone's pointing their finger at the pharmacy benefit managers, so the PBMs that kind of sit in the middle of all of this. And they say, well, the pharmaceutical companies say, well, we're giving our drugs at a fair price. And then it's these pharmacy benefit managers that come in and they crank up the prices and they charge like a spread price. So they say, okay, well, we're going to make X amount of dollars on this and give it. And then they set up their deals with Blue Cross and Point 32. So Blue Cross uses CVS Caremark, Point 32 uses Optum. So these are the pharmacy benefit managers. So everyone's pointing their finger at everybody. And so right now we're trying to figure out, do any of these executive orders actually do anything as far as moving the needle when it comes to the cost of care? The expected impacts are huge, but we'll see. But this is at least what's happening. It's out there in the national news right now. So for better or for worse, it's out there. Now, when we get to our local news, not quite as good a, excuse me, not quite as good of news for what's going on specifically here in Massachusetts. So nothing new here. This is information that we kind of knew, but between Blue Cross, Point 32 Health, Mass General Brigham, they've been in the news for all the wrong reasons the last 2 or 3 months, and we're talking large operating losses, specifically citing GLP-1s. Um, Mass General Brigham, not only did they have an operating loss, they have a budget shortfall, and they had major layoffs. So they had a big nurse layoff. I think the original thought was they weren't going to lay anyone off, but then the initial round of layoffs was, I believe, 1,500 nurses. And I want to call your attention to the middle article on the right. So the Health Insurance Agency for Massachusetts state employees will run out of money on Monday. So this just happened last week. So this is for the GIC. So if anyone's ever been part of a municipality or a state-run organization, the GIC has been a major provider for healthcare. So they basically went to pass a bill. It got denied, although they did pass a much smaller bill, and I believe it went through yesterday or it's on its way through. But the main thought process behind the entire thing that the GIC is struggling with now is they have more claims than premium dollars coming in. It's a pretty simple equation for health insurance, as complicated as it is behind the scenes. The equation for how are we doing isn't all that complicated. And so even within this article, they talk that the GIC was worried that maybe even providers would stop getting payments. And when you stop getting payments, that's when patients stop getting care, and that turns into kind of a mess for people that are within that GIC program. So again, healthcare in the news, not the right reasons. If anyone wants any copies to these articles, we're more than happy to pass them along. So these are all articles from the Globe. So all these ones on the right here, and even the ones, the prior to on the executive orders from the White House. So if we're going to do a deep dive on healthcare, I think the thought process is let's do a deep dive on healthcare. So, a lot of deep dives on healthcare in the past have been kind of specific to, hey, let's self-fund or let's try to change things. Or what we want to do is basically give a big snapshot of what's going on in the marketplace right now. So these are the largest payers by market sector. So that's just a fancy way of saying this is where all the members lie within the jumbo, within large group, mid-size, small group, and then the individual purchasers. Not a surprise, Blue Cross Blue Shield has the majority of the market share. Harvard Pilgrim and Tufts obviously are there. United Healthcare is a big player upmarket in the jumbo employees, not as big of a player in the small group marketplace. So when you go down to under 500, especially under 100 employees, they typically only offer a level funded platform, which we are going to spend some time talking about what level funding means later on in this presentation. Cigna is there in the large group and the jumbo group. Not so much in the small group to mid-size, but something that Apex is going to bring to the table is we actually hope to change that with our association plan because it leverages not Cigna as a carrier, but Cigna's network, which Cigna is one of the largest networks across the country, along with the Blues, United Healthcare, and Aetna. But this gives just a good snapshot of what does it look like in the marketplace, who's where. And so when you're talking about Blue Cross is struggling, Harvard Pilgrim and Tufts are struggling, Mass General Brigham, this is the majority of our marketplace. And I know most people on this call fall onto the left side of this sheet, probably between small, mid-size, and large groups. So Blue Cross, Harvard, and Tufts and Mass General Brigham struggling financially. And not only struggling financially, but outlining right in these articles and right in their press releases that they're going to update rates to reflect these financial struggles. Not to read between the lines, but we're really not even reading between the lines there. Healthcare prices are going up. It's just that's what's happening. They're going up. And what we want to do today is talk about some ways to help control that spend, not only from a carrier standpoint, but from a wellness standpoint. And again, we'll get into GLP-1s in a minute, but we want to spend a little bit of time talking about what's going on in the state right now. So obviously, here's your large payers. Next slide. This is an important one. So it's hard to control costs if you don't know what your costs are made up of. So when you talk about $1 of healthcare premium, a quarter of it is prescription drugs. So as we get into some of the GLP-1 slides coming up, the prescription drug numbers are staggering, and that's just GLP-1s. That doesn't even count all these other specialty medications that are out there. But we have prescription drugs, we have hospital costs, we have doctor's visits. So those are all lumped into your inpatient, outpatient, ER. That's your hospital services. Doctor's visits include ambulatory and then some of your labs and outpatient care. It's kind of like your Quests and your Shields MRIs. And then there's a bunch of administrative costs that are lumped in at the end as well. Carrier profit, administrative expense. This is where your broker fees come in. So what Apex does for our clients, our fees are built into these costs, which is why we take our role seriously because the dollars that you're spending, we have dollars that are in there as well, and we want to make sure that we're earning our keep and protecting your premium dollars. So it's just a good visual representation of where sort of if you're thinking, okay, I spend $1 million in healthcare for my company, 250 grand of that is going to be prescription drugs. $400,000 of it is inpatient and outpatient. Those are your large losses that we're going to talk about. The smaller portion, your doctor's office visits, those really only represent, 10, 15% of your overall costs. So when you start to break it down, that's what a dollar of healthcare looks like. So obviously, why are healthcare costs increasing? So on our chart on the right, the top two, that's your outpatient and your pharmacy costs. Those are the ones that are increasing at the largest rate. Not overly surprising there, but some of the other things. So obviously the post-COVID claims, we're going to talk about this again later on in the presentation when we talk about, you know, when it comes to renewals, what are we looking at? What are we doing? But the post-COVID claim run up, we're going to talk later on about a quote unquote lazy renewal process. And, if you rewind back a couple of years, healthcare was great. It was COVID, people weren't using it. We were getting single digit increases across the board, maybe no increases at all. And it was very easy just to, great, we don't have to put much horsepower behind it this year. Let's just renew, move on. Employees will be happy. Great. And it misses an opportunity to take some time and really do some consultative work within your program. So that's part of it. We'll talk about that again later. Obviously, cost shifting, there's nothing else businesses can do at this point. Um, but the bottom two drivers, the consolidated healthcare system. So obviously hospitals merging, but then carriers merging. So again, we used to be Massachusetts was a state where you had Blue Cross Blue Shield, you had Harvard Pilgrim, you had Tufts, you had Neighborhood Health, which is now Mass General Brigham, you had Fallon in Western Mass is Health New England. You had all these different carrier options. And then as we've sort of gone 5, 10 years into the future to now, we're really looking at two major HMO carriers, which are Blue Cross Blue Shield and Point 32 Health. The old Neighborhood Health Plan, which was Mass General Brigham, that used to have its place as a carrier where there was a big premium delta because the network was smaller. Well, Mass General Brigham now has a big partnership with Partners Healthcare. So those premiums have the premium deltas between those and Tufts and Blue Cross have kind of shrunk a little bit. So those are really your options. And if all three of those carriers are dealing with big losses for the same reasons, citing rates going up, you're kind of in a system where there's really nowhere to go. So you're with one of those three carriers. The other carriers might be, a percent or two off of each other, but that doesn't really move the needle if you're looking at, and we're going to go through a client case study looking at 25% and nowhere to go. And then we obviously know we're in a state where, again, Mass General Brigham, the actual hospital, just laid off 1,500 nurses. So when we're talking about delivery of healthcare, now we're struggling on the delivery of healthcare side as well, as far as on top of just offering affordable healthcare. And then specialty drugs, we're going to talk about extensively with the GLP-1s as we get into some later slides. But when we're talking about, okay, well, let's see what's our average. How are we doing as a business? And it's like, so most people on this call, the average deductible is a couple $1,000s. So the days of no deductible plans are gone. And I would argue from what we've seen, at least within our client book of business and what we've seen in the marketplace, the average is probably closer to $3,000 than it is 2,000 right now. And when you get into the larger groups, obviously people expect, as you get bigger as a company, people expect better healthcare. Sometimes that reasoning isn't logical and it's not the way that works, but that's what employees expect. So that's where we are. And then you can see the differences of your office visits, mental health, inpatient, generic drugs, et cetera, down at the bottom. On the right, so these are, when we're talking about what type of benefits, what does it look like from a mean? On the right is, well, let's talk about, can our employees even afford these benefits? So this breaks it down affordability by race, and you're talking between whites, Hispanics, Asians, etc., who's experiencing affordability issues with healthcare? That's on the top. And then on the bottom, who is not getting care they need because of those affordability issues? So what we want to do is we want to think about, okay, what's our employee population look like? If we fall within one of these areas, what are we doing for our employees to make sure that they're not deferring care and to make sure they can actually afford the care that they're getting because it's expensive? So as we start to unpack healthcare again, it's well beyond just let's put numbers down on a spreadsheet. We're looking at premiums, we're looking at copays. Let's find something that makes sense and move forward. We really want to start to do a deep dive on what does it mean to offer healthcare to our people and what's going on within the healthcare system. And there's no better time in an ideal world, there's no better time to do that when things are going well. In a less ideal scenario, it's almost something you have to do when we're looking at the marketplace that we're looking at right now. And this was a great example. So the 2025, the Consumer Health Annual Report has some great information in it. And I just pulled, they had um, these little case studies here, and I pulled two of them. There are a couple more in there, but let's talk about a 6.5% increase and an 8.5% increase to healthcare costs for two different types of people. One, the person on the left making $60,000, small business, has some small health things going on. You're at a monthly budget deficit with this type of healthcare going up 8.5% every single year. And so we think like, okay, if we get an increase of 5, 10%, great. Let's just move that forward. And employees, it's only 8.5%. By the time you do it pre-tax, not a big deal. It turns out being a big deal as the rest of our costs in our lives go up. And we know we had an egg crisis, which I think has subsided a little bit, but the jokes in all of our circles of friends talking is like, the best investment might be to go build a chicken coop in the backyard and buy a dozen chickens, and then you'll have eggs for free forever. So healthcare is a cost that's going up, but it's not the only cost that's going up. And so then we go on the right. This is a combined household income of $150,000. That's not a small number, but they need family insurance because they have two kids, a mortgage, childcare. When you're seeing healthcare costs go up 6.5% for that person, I mean, that can potentially bring a budget shortfall of over $3,000 a month. Like that's not a small number. So when we're talking about, I think part of what some of these stats have brought to the table for us is really making sure that what we're doing really fits in with our employee demographics and understanding what we can do to help employees holistically. Healthcare costs, sure, but then as we go through the rest of the presentation on some of the other things they might be struggling with. Um, I'm going to quickly pause. So just that's our kind of market snapshot. We're going to dig into the healthcare carriers' response to some of these, and we're going to do a big deep dive on GLP-1s starting right now. I just want to pause quickly and see if there are any questions kind of on that first section, just teeing up what's going on with healthcare right now. I don't see any, so I'm going to just keep rolling. So GLP-1s. So I'm not necessarily going to read through all of this, but there's a lot going on here. And we're going to go through some stats and some slides moving forward about what's the craze? Is it working? What's the cost impact? Obviously, the carriers have made their stand, and we have updates from the carriers as recently as Point 32 sent out their update yesterday. Um, but there's an explosion going on here around these drugs, and it's part of the reason why we reached out to Paige at Awaken 180 Weight Loss, because when you start digging into some of the costs of these and some of the results, and I'm sure everyone on this call knows someone that has taken Ozempic or Wegovy or whatever, and it works. I mean, it's not a question of does this work? It's more a question of is it actually preventing future claims? And there's a study we're going to see here that someone did that they kind of did a projection into the future where might be debatable. And even with it working, is it worth the cost? And so we're going to kind of dig into all of that information. So this is a a chart. This isn't cost. This is Google searches. So if we go back to basically, this starts at the pandemic. This is Google searches for GLP-1s. And obviously, it's on the rise significantly. We've had conversations with clients that employees are coming to them weekly asking for access to these type of drugs. Unsurprisingly, the next sheet is the amount of prescriptions filled for GLP-1. So when you start to look, and this, so the Mass Health Policy Commission, another fantastic resource for anyone out there. This is actually an interactive chart, so you can filter by drug, et cetera. I obviously just have a screenshot of it here, but um, this Health Policy Commission, I have some more data from there in here. Unbelievable talking about what's going on within healthcare. And so this only runs up to 2023, but obviously we're going extremely I wouldn't necessarily call it a smooth curve. And the Wegovy's and Ozempics are that kind of yellowish orangey 55% in 2023. And so, they haven't filed the 2024 information yet within the Health Policy Commission report, but we know what's going on with Blue Cross Blue Shield. So let's just keep an eye on this graph now. So 2023, we see where it's going. The next page, 2024 GLP-1s, the prescriptions were up 255% from 2023. So think of that slide before, the arc that it was on going up. 2024, the prescriptions have gone up 255%. And Massachusetts is one of the states across the country where they're the highest rate of new patients that are taking GLP-1s, only behind Oklahoma and Rhode Island. So New England here has two of those states. And obviously, I think anyone who's been to the doctor, had blood work done recently, I talked to someone over this weekend. It doesn't take much to be found in a pre-diabetic stage. I actually think last time I did my blood work, I was pre-diabetic, and I'd like to think that I'm relatively healthy in the grand scheme of things and try to eat really well. Um, But obviously, part of this whole GLP-1 thing, and does the benefit today outweigh the long-term cost? Is, there are studies that show that there are some side effects, and if you stop taking them, um, there's a chance you can put all the weight back on. So again, when we start looking at the costs of these, it's like, okay, if we don't have behavioral change along with these drugs, then you could be spending a lot of money for a couple years worth of relief and then potentially going back into the same issues that you were back in beforehand. And so when we're talking about what who in the population are being prescribed the most. So again, the Policy Commission has a nice little chart here. We don't necessarily have to go through all of it, but it's pretty evenly split between female and male. The female looks a little higher on this chart, but in the grand scheme of things, it's pretty evenly split. Prior diagnosis of diabetes, though some of them do have it, some of them don't. Diagnosis of overweight and obesity, I think as if this chart were updated for 2024, those numbers would be significantly higher given that last chart. Um, and given the fact that the health carriers believe that the adjustments that they're making to their GLP-1 coverage is going to affect somewhere between 100 and 150,000 members. And I believe that was just Blue Cross Blue Shield. So when you talk about Point 32 Health, Mass General, Brigham, all the other carriers, there's a large portion of the members that are going to end up being affected by some of the changes that are coming up. And so this is a slide I'm going to call back on later. So we don't have to remember these numbers, but I'm going to put it back into a future slide. But there are already studies out there that are saying the GLP-1s, despite the fact that they work, they might not be quite as effective as we think they are. And that's where we've had those conversations. It's like, well, if we can get somebody healthy, someone who's either a type 2 diabetic, pre-diabetic, if we can get them healthy, and healthy in quotes because we don't necessarily know the long-term effects of some of these drugs, but I would say in a better position from a weight standpoint and potentially from pre-diabetic or diabetic to not diabetic, that's going to outweigh their future costs within the healthcare system, right? If you prevent something from someone later on, great. A couple articles here, again, happy to pass any of these around that are disputing that. but this JAMA Health Forum, and I hope I'm saying that right, but you can look this study up, but they did a projection out based on everything going on right now. And it's what's the obesity related health savings versus the medication cost and the net overall spend. And their projections don't show savings at all. Their projections actually show that the costs are going to far outweigh the spend. Now, if I played devil's advocate against this, I'd say, well, going back to one of these executive orders, maybe we start getting these prescriptions for a lot less expensive um, than we're getting them today through the health carriers. So maybe that does offset this a little bit. But just know there isn't, I don't think we're at a place where we can say there is a direct correlation to these drugs are worth the money right now because we haven't had enough run out to know what's going to happen in the future. And so as we mentioned, I think everyone, if anyone connected to us has seen these, but for anyone out there that hasn't seen them, major responses from Blue Cross Blue Shield and Point 32 Health. Point 32 Health as early as yesterday. Um, but obviously, starting 1/1 of 26 for Blue Cross Blue Shield, GLP-1s will not be covered for weight loss. So they'll continue to be covered for type 2 diabetes, but not for weight loss anymore. And so for groups over 100 employees, you actually can put a rider in place to continue offering them for weight loss. It's an 8% load to your entire rate. And so I'm just going to time out here for a second and go down to the bottom. We're going to do our best to hopefully make sure that companies don't take that option. We tend to not like to take such a firm stand one way or another, but this is one where we're really going to take a firm stand. And even if you look at the box on the right, Blue Cross basically gave you the reason why. This was in their update to the GLP-1 coverage. They gave you the reason why that rider doesn't make sense because higher premiums affect all members and employer groups, whether they use the medication or not. That's the exact reason to not add that rider to your health plan. So if that's brought up as an option, if you want them to be available for weight loss, we're going to talk about some options in a couple slides that are a much better option that doesn't do exactly what that Blue Cross box is saying. If you have specific members that want it and it's carved out of your plan, we have other options that doesn't impact your entire plan cost. All of your employees, every employee paying a contribution into it, not just this year, but for every year into the future. Right? If you're adding 8% to your rates today, when you get an increase 5 years down the road, it's going to be based on that 8% that goes on there today. There are just better ways to do exactly um, what this rider is theoretically doing for these groups. On top of that, we talked about prescriptions in general. Like we're focusing on GLP-1s right now, but prescriptions, if we go back to our little dollar bill of $1 of healthcare spent, it's not just GLP-1s that make up that 1/4 of every dollar spent. It's all prescriptions. So Blue Cross Blue Shield taking another step, effective July 1/25. So this is like 6 weeks away from today. Humira is no longer going to be offered within Blue Cross Blue Shield of Massachusetts. It's super expensive. It's an expensive drug. So then there's two biosimilars that are going to be there to replace it. And there's actually a program where eligible members can get it for $0. So it really is a win-win-win all around, unless the biosimilars don't work as well for those particular employees. And then again, there's no solution to that. They're just simply removing an expensive prescription from their formulary. So this is the first we've seen of something that targeted, where we always, when we say, hey, expensive prescriptions, if you see a commercial on TV, it's probably pretty expensive. So Enbrel, Humira, like this is the first time we've seen a carrier take a stand and say, there's a biosimilar that obviously I'm sure they've done all their research and said it does the exact same thing. And so now not only are we going to suggest you do that, like the typical step programs, we're going to make it the only option if you need a drug like that. So something we're seeing a change within that. And then as we get to the Harvard Pilgrim Tufts Point 32 slide in a second, you're going to see a major change. But So this is Blue Cross's stance. And if anyone needs like a notification, we do have like a one pager, like a one page branded like Blue Cross pharmacy update thing. So we can send you that. We have one for point 32 health as well. I think it should be done by the end of today because that notice just came out yesterday. So some of the things, so within that same notice where Blue Cross said, it's expensive for all people, don't do that. This is their response to what does this change mean to members who are currently taking those drugs for weight loss? And they say, what if people still want to use it? And so they basically say, well, here are the options that we provide those members. So these are the wellness programs built within your Blue Cross Blue Shield medical program. And so they're all in there. But again, these options are your lifestyle change options, not what's theoretically easier, which are the GLP-1s that you take once a week. So this is where the carriers are pushing. They're saying, go down this path. Let's do holistic. Let's focus on nutrition. Let's focus on exercise, get one-on-one nurse counseling. A reminder, you can get a gym membership and go work out at the gym. So we're seeing, I think we're going to see a big push for wellness programs coming up in the next, I would say definitely leading up to 1/1 of 26 when all these GLP-1s are stopped from a coverage standpoint. So point 32 health, they've taken a very similar stance. So obviously they separated between the merge market and the large group market, but pretty similar. Merge market, they're just simply not going to be covered for weight loss. Large group market, they have a little bit different stance. They're focusing on Zepbound. That's going to be their preferred drug of choice. But this just came out yesterday. So if anyone's taking the GLP-1s for weight loss, and that would be the Zepbound, because they're not offering, per the notice on the other side, they're not offering Wegovy and Ozempic anymore. They've focused on Zepbound's going to be their drug of choice. So if anyone's on Ozempic today with 0.32, starting for weight loss or even for type 2 diabetes, I believe, starting 7/1 of 25, no longer. It's going to be flipped over to Zepbound. But starting 1/1 of 26, if you're using it for weight loss, if you want to continue using it, you need to participate in a behavioral modification program for 6 months. I'll repeat that. Participate in a behavioral modification program for 6 months. Just came out yesterday. Upon completion, if you meet the criteria and you continue to have coverage, then you'll still be eligible to receive the drugs, etc. So that is a wild change to anything that I've seen in healthcare where we've seen like step therapy, we've seen you need to try generics first, this and that. This is a 6 month basically nutritional weight loss course. You need to do that first before you can get access, and then they determine if you still need access at the end. That's the first I've seen where you need to have, it's a behavioral issue when it comes to getting a prescription where you have to try something for 6 months before you're able to get the prescription. So if that notification alone isn't like a big red flag that healthcare is changing wildly, like right before our eyes, I was really surprised to read that when that came through. And again, that just came out yesterday. So if you haven't seen that, don't be surprised. We have this notice ready to go. But so for anyone with point 32 health, that'll be an interesting means of communication for all of those January renewals and beyond about members that are on those drugs and what does this behavioral modification program mean? So we found that to be an overly interesting notification that came out yesterday.
Hey,
So,
Jeff, I
yep.
have a question. What if there are people that are on one of those GLPs now? Like, so for instance, I believe I'm aware of someone. So how are they getting are they getting these notifications directly, especially from Harvard? I mean, that's a July 1st, effective date. So that's pretty much a month.
Yeah, I would say theoretically, I'm sure they are getting a notification from Harvard Pilgrim. So actually within this notice, they talk about, I didn't have enough room to stick it on this slide, but they do talk that members will be notified. But yeah, it's going to be something that, again, it's going to be something that's going to happen in 6 weeks. It's like, so for all those Harvard Pilgrim members, and I'm sure there's a bunch of them that are on anything but Zep bound, they're going to have to do something different within the next 6 weeks. So I would say yes, they are going to get notified by the carrier, but as best practice for a business, and this is where for us, this is where as for our clients, we want to make sure they're aware of this. So we have a big email going out to our clients with the slides from this deck with all of these notifications once this webinar is over. But if anyone wants to be added to that, we're happy to include that, because I would say best practice is to try to give employees a heads up of a change coming, in 6 weeks.
Okay, great. Yeah, because I haven't seen anything from Harvard, a notification of any sort, to send off to the employees, but definitely would like to get something out.
Yeah, and I'll include that one where it talks about we have a notice for each, so both Blue Cross and Harvard. So if you guys are Harvard, I can flip over the Harvard one just to make your life easier, because it has all of the notices about this notice for 7/1 has a bunch of bullets about how members are going to get notified, et cetera. Like I said, I didn't have room for them on the slide here. So
Okay,
we'll make sure to send that out afterwards. Um,
thank
and
you.
then very similar to Blue Cross, they're going to have a buy-up program for, groups over 100 employees. Again, we're going to do our best to throw our bodies in front of that, because there's just better ways to execute the same thing without just adding fixed cost premiums to your medical plan, which no one wants right now with the fixed cost premiums on the rise based on everything that we've talked about. And so when we talk about healthcare, people who have worked with us with the PFA have seen this slide before, but the slide holds true. It's why we always go back to it. So it's, the balance of healthcare is, we call it the 70-20-10 rule. And 70% of your people are relatively healthy. They barely touch the healthcare throughout the course of the year, maybe less than $1,000 in claims. 20% of your people are dealing with something. And that could be someone dealing with type 2 diabetes, someone dealing with high blood pressure, someone dealing with a managed, chronic condition that maybe spend between $5,000 and $10,000 a year on healthcare. Your 10% of your people drive all your costs. So they're driving your large losses. So if we go back to that dollar, you know, 25% healthcare, 40% is your inpatient and outpatient services. This is where there's 10% of your employees that are probably driving most of those 40 cents on every dollar of your costs. And so the big game in healthcare is, what do we do? How do we not underinsure the people that need it, but realizing that most people don't need it at all? And so how do we create this balance of, what do we do? And I think now, if we looked across our entire book of business, probably the average individual rate, I will say not on our association plan, is probably somewhere in the $800 a month range. Like, that's a huge number. So you're talking $10,000 a year for the average individual. And if 75% of them, 75% of them spend less than $1,000, like that's where we're trying to, how do we, not game the system, but how do we figure out, okay, if you're a winner, great. How do we make sure that you're not overspending? If you have a population that isn't as healthy and you're getting big increases, well, then how do we take advantage of this? Because the reality is that it's probably not your entire population isn't healthy. There's probably a certain percentage of people that just have large claims going on. That's okay. We have resources for that. So this is kind of the healthcare conundrum. And this is where we firmly believe at Apex that there needs to be a bunch of innovation around how healthcare is offered. Now, self-funding is still a way, and we'll talk quickly about just some self-funding info later on, but it's a way where you can get around that. The reality in Massachusetts is that 99 out of 100 groups don't even want to have that conversation. So if that's theoretically off the table for the time being, what do we do? Because like we said, we have Blue Cross, we have Point 32 Health, we have Mass General Brigham, Western Mass, we have Health New England, but really that's it. And if everyone's rates are going up the same, then you're kind of in a position where, what do we do? And so we want to go through just renewal processes in general. So I think if someone gets a large health insurance increase today, obviously that means your claims are high, right? Like you're one of the groups where maybe you're spending a lot on GLP-1s and um, there's a bunch of large losses or whatever the case may be. But let's talk about some of the less obvious things within a large healthcare increase. We could have plan design mismatch. So if the plans are just too rich for what your members need, adverse selection. So obviously, if, excuse me, when we talk about the risk pools, if there are employees that are dominating the risk pool that might be skewing the cost projections, especially in the small groups, this is where we might be able to make some adjustments with a program like we're going to show you in a second where we can do that. Carrier negotiations, this is something that you think is totally equal across the entire playing field, but there are some people, and Apex, we believe, are one of them, that just professionally push harder. We push harder for our clients because we're advocates for our clients. So you want to make sure that you have someone advocating for you, and it's not a typical, hey, we don't need to look at this year because, again, it's 6.5%. And if we go back 10 slides to the 6.5% for someone making $60,000, it puts them in a bad position. So um, benefit misalignment's a big one. That's one that doesn't really get talked about as much. High cost drugs. There are ways, again, we're talking about these GLP-1s. We're going to go over a couple ways in a few slides, how we actually can move around some things. So it's not just, okay, we get a big increase, there's nothing we can do about it, and no one else is competitive. So I guess we're just kind of stuck here. There are absolutely things we can do. And then this one's going to be similar for, we have a slide in a few slides talking about a small increase, um, reactive versus being proactive. I mean, planning throughout the course of the year and understanding where things are as you go along helps make all these other things above it. You bring those to light beforehand before you get into the fire drill renewal process. And sometimes they're unavoidable. Where I'm in one right now and it's unavoidable. Um, Sometimes you just need to have a fire drill once every 5 years. It's just the way it's like once every 5 years, your claims might be high. Once every 5 years, your renewal is a fire drill. It happens. But at least if you're having these other conversations, you're at least you're at least digging into every area you can dig into within a renewal to make sure that there's not an area where maybe we're just misaligned with how we're looking at our own risk pool, how we're looking at our employee needs, how we're looking at our offering, et cetera. So we're going to go through a quick case study. So this is a client with Harvard Pilgrim. Costs were increasing by 25%. They're a large group, so this was heavily claims driven. Um, this one also might have been, a little bit plan structure driven. So, there were very rich plans, and there's a reason for it. So there's a whole reason behind it. But it's like, okay, we're going to focus on our top box in the darker blue. So we used our PFA with this case study. Their renewal was going up to about $1.5 million. I want to bring your attention to the employee contributions at the bottom. So when you see the in the highlighted in the yellow, so the employee contribution versus the employer contribution. So we want to make sure that before there was a 60% contribution. So the employer paid this much, the employee paid this much. What we were able to do with the PFA, and for anyone that needs a deep dive on the PFA, we have a bunch of webinars out there, but we can show you, et cetera. It's not super rocket science how it works. You buy down to a smaller plan. The next slide talks about how it works. You buy down to a less expensive plan. We use a debit card offering to help buy back benefits for employees. So for our 3 plan offerings, we were actually able to, so they got a 25% increase. Our PFA got them a 25% savings. So their renewal was basically zero. So what we did with our first plan on the left, we kept it at no deductible. Those employees have no deductible exposure. So again, when we talk about that slide that an average company in our marketplace has a $2,000 deductible, these employees have no deductible. The other 2 plans, we went from $2,000 deductibles to $1,300 deductibles. Employees had a debit card that funded their first dollar coverage. But look what happened on the financial side. So what our client did, again, going back to the slides of our 2 people one making 60 grand, one making 150 grand, and how much an increase impacts their daily life. Our client, rather than taking all the savings, they said, you know what? We're going to keep our contributions the exact same as they were on our renewal. We're going to leave our contributions there. And look what happens to the employee contributions at the bottom. So the box is highlighted in yellow from the top to the bottom. So these employees went from, I'll just use that $0 deductible plan, spending almost $600 a month, and almost got cut in half. They went down to $357 a month. A family went from $1,400, almost $1,500 a month, down to just under $900 a month. So again, when we talk about what's available, this was a scenario, and we're lucky enough to be one of the few brokers that have the PFA. But if you didn't, you had a 25% increase with Harvard Pilgrim. Blue Cross, no thanks, declined to quote. Mass General Brigham, same thing. Even our association plan, we looked at it, didn't work. And so there was nowhere to go. So the only option for this group would have been, well, let's just cut our benefits. We can't offer a $0 deductible anymore. We have to take our $2,000 deductibles to $4,000 deductibles. That's the solution in this case. We're here to tell you there are other solutions. And this is a perfect example where not only did we eliminate this entire renewal from a cost standpoint, we actually gave the employees better benefits than what they had before. And so the second slide is just going to quickly go over. Most people on this call have probably heard of an HRA. A PFA is sort of a cousin of an HRA. But typically what happens with an HRA is that the high users are the ones that get those benefits. So typically in HRA, you pick a higher deductible. Let's say for the example we were just looking at, if we went from a 2,000 to a 4,000, it's like, okay, well, let's make the employees pay the first 2,000 they typically would have paid anyways. We'll pick up the last 2,000. So the only employees that get the benefit of those dollars are the employees that are the heavy users that go beyond whatever the number is within that deductible. And so it ends up creating a little bit, we call it unintentional discrimination. And we know a lot of people on this call are in HR. Discrimination is not a word to be used lightly, but it's kind of in air quotes, unintentional discrimination when there's an HRA there. Because it hits only those heavier users. And even if you theoretically pay the front end of the HRA, if you have healthy people, so if you pay first and have the employee pay last, if you have healthy people on your plan, they're probably not spending deductible dollars. They're using office visits and, urgent care and maybe some prescriptions. So the reason we like the PFA with the debit card is that that's first dollar coverage for those employees. So from $1, they have this debit card to subsidize their benefits. So not only on that last slide did all of their costs come way, way down, their out-of-pocket costs came down. Even the people, the $0 deductible, obviously you can't go lower than zero, but the people on the 2,000, their deductible exposure actually went down to 1,300. So they actually have less deductible exposure than they did prior. And then they have a deductible to protect the first part of they have a debit card to protect that first part of their deductible. So now everyone on your entire plan gets the benefits of using these PFA dollars. So does that make sense? I'm trying to follow the chat here as well. I have the chat up on my phone. Oh, yep, Kathy mentioned the PFA. Thank you, Kathy. But so we want to tell you, so the point of this case study, again, large renewal, nowhere to go, decline to quotes in the marketplace. It doesn't mean there's no options. And so the PFA is a great option for that. Let's talk about a small renewal. So if you remember, I went back on that very first slide of key indicators of rising or not, being complacent when it comes to seeing trends happening. We're basically in that right now. So we're seeing the COVID trends from 2020 through basically 2022-ish, maybe into 2023 a little bit, where utilization was just super low. Like people just didn't use healthcare all that much. And so now we're saying, okay, well, we're going to dub it strategic complacency, where it's like, okay, well, if nothing's happening today, what's coming? Can we plan for what's coming to make sure that, when something does happen, that we're ready for it and we've planned for it? So that's kind of the situation we're in right now with GLP-1s. And, I don't think anyone could have predicted the GLP-1 explosion that happened. But it's just saying the point of this slide is that just because you get a small renewal doesn't mean that there isn't anything that we can do. And we have two great case studies to go through that. So one is a small company on the Cape. This is a client of ours. Um, they got a renewal. They have pretty rich plans, $1,000 and $2,000 deductibles. These are the boxes in the top, sort of in the blue. They got a 4.5% increase, 4.65%. Most people would look at each other, high five, move on to next year, right? Like 4.5% is like well within budget. That's below trend. Awesome. We don't have to do anything. We don't have to change anything. We can just rerun it for employees. Well, employees were paying 50% of the cost of these plans. And these plans, like looking at these premiums, I mentioned the average individual rates probably, $800. These rates are at $1,200. And then 950, almost $1,000 for the 2000 plan. So when you're talking about this is a construction company. So it's, not people that are they're not necessarily living paycheck to paycheck, but it's not people that $600 a month for healthcare that they really don't use. That's a big deal. So this is where we brought in our association plan. So for anyone that's chatted with us, quickly, it's available for groups under 100 employees enrolled. So if you're over 100 employees, we have some better solutions for those. But for under 100 employees enrolled, and we say if you're a winner with the carriers, this is where my partner John talks about this. If you're a winner, meaning the carriers like having you as a client because your premium to claims, it's a good number for them. This is a great example of where there are other options out there. And so we were able to use our association plan, which isn't Cigna as a carrier, it's Cigna as a network. So we use the Cigna network. And we were able to put our $1,000 deductible to match their current 1,000, and then a $1,500 deductible to basically give them a little bit better plan from their 2,000. We actually have 1,000, 1,500, and 2,500. We don't have a 2,000 plan because it's canned plan offering. We're able to lower their costs by 45% compared to that renewal. So when we're talking about, okay, let's talk about healthcare. Like if we can get like a 5% increase at the top, usually we high five and walk out of the room, right? I mean, I've done it. I know if you go back the last 15 years of my career, it's, 5%, great. But things are changing. And so as things are changing, we need to change as brokers on our side of things and say, okay, well, 5% is great, but maybe there's something better out there. And in this case, we have something a lot better. And we see almost a 40% decrease in savings. So what was able to happen with this client, again, I keep going back to the slides with those two people, those two examples from that study about getting a 5% increase and what that really means to their paycheck. This client was able to bump their contribution instead of 50-50. Now they're going to do 75-25. And instead of 75, that 75-25, the 75% is actually less than the 50% they were spending before. So now we have this crazy scenario where they're able, like out in the open market, construction down the Cape, super competitive hiring, they're able to say, well, we offer 75% now, not 50%. And then you're 25% as an employee, instead of spending $600 a month on an individual plan, you can spend 25% of $700, like $165 a month. Those are huge, huge dollar savings. And as we've chatted with some association people down in the Cape, it's like that's a big deal for, like the Cape Cod in general is pretty close knit. It's like those dollars can get reinvested back into the Cape Cod economy. That's a big deal. Like, I'm not saying that this association plan solves any economic problems, but just in a vacuum, you can see how healthcare savings is a big deal. Like it's a big deal for both businesses and these employees. So then the other case study we have is a 10% increase on a larger group with United Healthcare. So they're headquartered out of New York. Very similar scenario. 10% with United Healthcare. It was justified based on they had a couple of large claims. It's justified. It was a justified renewal. It wasn't something where we would look at it and say, totally crazy, they're out of their minds. But again, if we look at the employee contributions in yellow, crazy numbers, just crazy, crazy, crazy numbers. And so our same association plan was able to come in and save them 46%, which again, having a large loss doesn't mean that you immediately need to get a big renewal. So when you look at the employees, again, on that top plan, the $1,500 deductible plan, we matched their best plan and we enhanced the other two plans. But you're talking an employee saves almost $650 a month on their healthcare contributions. Like these are big dollars, like big dollar savings where again, we'd be happy to look at this association plan for anyone, but the goal here is to make sure that you know that it's at least an option. And so these are two examples of, and I guess it's crazy we're calling it 10% a small renewal in today's day and age, but the reality is based on where the healthcare carriers are going, it actually might be a small renewal, unfortunately. But the goal is to make sure you know the options that are out there for you. And so when we talk about knowing the options, so let's really talk about them in Massachusetts. So we have Blue Cross, Point 32, they're Harvard and Tough combined, Mass General Brigham, Health New England, United Healthcare. We have different, so all those at the bottom are different funding mechanisms. Everyone, HRA, we talked about PFA, HSAs, I think are going to become much more prevalent in the state. And an HSA, that's where our PFA platform with a debit card provides a nice bridge. But these contracts, they're called paid contracts. That just means you pay your premium and the carriers pay all your claims. It's not, you don't see anything behind the scenes. It's just you pay your premiums. And so an example, so if a claim happened today, but then we change carriers on June 1st, but the claim isn't received until after June 1st, our current carrier today is going to still pay that claim. So if we're on point 32 today, we switched to Blue Cross for 6/1. I had a claim today, but it doesn't get processed until 6/14. Point 32 is going to pay that claim, not our new carrier. So obviously we have self-funded options. So Blue Cross just came out with a level funding option. They actually just came out with a PEO as well. They have level funding. We have level funding with Aetna, Cigna, and United. Trustmark. We have our captive. So InCap, our captive. So we, in our prior life, we were on that at our prior company, even as members. Worked great. But these type of contracts are done a little differently. So it's not so much you pay your bill and then you're done. So they're paid on claims incurred the first 12 months need to be paid in the first 12 months. So in that scenario that I just mentioned on the fully insured side, we'll talk about how that would work a little differently. Now, if you renew on a self-funded contract, well, you renew for another 12 months. Well, now those 24 months of claims will get paid on a 12-month contract basis. But here's what happens when you leave these type of scenarios. And this is where we want to make sure, I know there's been some Aetna, Cigna, United level funding. I don't want to say messes, but I don't have a better word for it. When you leave. And so when you leave, you typically have to purchase something called terminal liability, which picks up some claims that are run out. So in our example on the left that I mentioned with fully insured, in that scenario, if you were level funded and you left for 6/1 and you didn't purchase the terminal liability, you as a company would be on the hook for that claim that didn't get processed until 6/14. So when we talk about, we see level funding out there, and a lot of times, again, level funding gets dumbed down to this is cheaper than my whatever, Blue Cross, Harvard, Tufts plan. So this makes sense for me. I'm going to move to it because it's less expensive. And some of these contract provisions aren't necessarily explained well. There can be a big liability, even if you just want to simply leave. And within level funding, it doesn't take much for a couple claims. Usually it works for as long as it works for, it's great. And then when it doesn't work, it really doesn't work. You usually see like a 60% increase. And so while you're staring at a 60% increase ready to leave, you're also staring at this terminal liability expense that maybe was explained to you, maybe wasn't, that you weren't totally sure about how it worked. And now you're looking at a big increase and a big expense on the back end of it. So we just want to make sure that anyone who's looking at those options understands all of that. And if you are looking and you don't understand some of that, reach out to us. So John, my partner, was a stop loss underwriter in the past. All these this is all his contract verbiage. John, hopefully I did it justice. So then we go on the right side of the page, and here's where it's like, where are we going if none of this stuff works? So obviously our association plan is there. So again, it's not like a Cigna plan like I just talked about. It's the Cigna network, and it ultimately functions like a fully insured plan. You can jump into it and out whenever you want, just like you could with Blue Cross Blue Shield, Point 32, Harvard Pilgrim. PEOs are out there. So as I mentioned, Blue Cross just came out with their PEO. ADP Total Source, Insperity, TriNet, Oasis. There are a bunch of other ones, but understand PEOs they typically have contracts attached to them, hopefully just 1 year. Um, the fees are usually pretty high on a PEPM basis, but you do get a lot for them. But just make sure, again, as we do like a strategic renewal sit down, it's like, are we using all of these fees, or can we replicate this in a different way that's way less expensive? Um, and then you typically have to pay a penalty if mid-year you say, like ADP Total Source renews June 1st. So if you decide, you know what, July 1st, I want to do something different, you typically have to pay a penalty for that. So just make sure you understand on that. And then the big thing that we're seeing rise as kind of, we have always thought of it more as a last resort because offering healthcare is important to a business from a, feather in your cap standpoint. We have that slide from prior webinars where pay is the first thing employees care about, healthcare is the second thing. So basically offering this ICRA, which is basically you just give employees money to go buy healthcare on their own. It's really seen as almost like I don't want to call it a pay decrease, but it's really not seen as a benefit that lines up with how the Massachusetts market has historically been. Now, doing things the way it's always been, that's dangerous also. But the ICRAs are out there, and there are companies that are saying, you know what, I have one large claim that I just can't get off can't get off the plan, and we can't afford our premiums anymore. So we're just going to do an ICRA and let everyone go and let the individual marketplace deal with it. Those cases are out there, and there are times where there are big savings doing that. Um, but just know you have to do, it's the trade-off. Does it make sense to, dump your group health plan and not have that as a benefit offering anymore versus here's some money to go to the individual marketplace. There are solutions where there are some white glove service to help employees navigate that. So, we don't want to necessarily make it seem all bad, but that is a major change in how we're looking at healthcare. So when you're talking about like renewal strategy and we sit down and we say, okay, well, let's talk about what's out there. There's a lot of things out there. So the one other thing I wanted to mention briefly, so RX solutions. On the left, your RX Saver is something that comes with all of our PFA clients. We actually have it as a company for Apex, even for clients that don't offer the PFA. So if you're a company that doesn't offer the PFA, but you know what, you want to have access to it, we have the ability to pass that along. The RX Safeguard, this is a solution along with another one I'm going to mention, RX Manage. The RX Safeguard is something where let's talk about the GLP-1s with Blue Cross and Point 32 come January 1st of next year. They're out for weight loss. They're just out. Employees do not have access to them. But let's say you as a company still want to offer them, but you don't want to, again, I jump in front of you when you say let's add the rider to our plan. This is a way to purchase those prescriptions, and you can give employees basically a debit card. You can fund the prescriptions for employees at whatever rate you're trying to fund it. We can talk about that. But then you have options so that you can buy through Mark Cuban, his Cost Plus, local retail pharmacies, and they mentioned you can use it with weight loss GLP-1s through Lilly, which is kind of a version of what your RX Saver is as well. Off to the right is what our captive looks like. We use Lavinity as the PBM. They're a full pass-through PBM. So when I talked about earlier, when Trump did his executive order and everyone's pointing at everybody else saying it's your fault, the one thing that we want to make sure that when we talk about if you do get into a self-funded scenario, your pharmacy partner, we do not like the pharmacy partners that do spread pricing. And there are a lot of some of bigger national consulting houses that have pharmacy consortiums, and most of them are spread pricing. It muddies up the water. You have no idea what you're paying for it. You don't know who is reaping the financial benefit of that spread. We just don't like it. So we do a full pass. Livinity is a full pass through. So whatever Livinity gets charged, that's what you pay as an employer. And then you see those rebates as well. On top of that, within our captive, we have a specialty carve out called Sharks. So they basically look at these super expensive prescriptions. We remove them from the Livinity formulary. So that way, if you go to CVS and you try to buy, I'm just going to use Humira because Blue Cross just mentioned it, you'll be able to get a fill there. They call it a grace fill, so that you don't you don't go without it. But then someone from Sharks is going to reach out to you and say, hey, this prescription falls within our program. You won't be able to fill it again through Livinity. We're going to go source it from somewhere else and make sure that you're getting the lowest price possible. And so within those programs, there are big savings to doing it that way. If 25% of your cost for every dollar is pharmacy, and now you're starting to move out the high cost prescriptions and you're getting rebates on the ones that you're using, all of a sudden you have dollars coming back within your program. And so I'm going to go through a quick client scenario within this. So self-funding. So as we mentioned, someone on here is going to find this pretty familiar. Within self-funding, so I'm going to kind of go to the bottom first. So pharmacy savings, that's our Sharks report. So this year was almost $135,000 of savings from removing the specialty drugs outside of that formulary with Livinity. That's a win. That's a good scenario. The other thing within self-funding that you don't see within the fully insured marketplace is this validation of claims. So I'm just going to draw your eyes to that red arrow. We had an outpatient scenario within a hospital that was billed at $2.4 million. We found out that 1.8 million of it was incorrectly billed. And so our actuaries caught it, they fixed it, and our total paid claim on a $2.4 million charge was $268,000. And obviously, if you look at the other line items in there, there's savings elsewhere, but this is just, that's just the biggest one. But even the top line, inpatient, we saved $300,000 over admin savings and reduction. Something must have been billed wrong there as well. If we go back to our dollar, 40% of our every dollar spent is, I mentioned, was outpatient, inpatient. There are scenarios where things like this could slide through on a fully insured basis. Doesn't happen all the time, but it can absolutely happen. And so that's where, and we really don't have any line of sight into it from a transparency standpoint when it's fully insured. We see claims to premium. We see, okay, last month's premium was $100,000. The claims were only 70. Great, that's a good thing. The next month they were 120. Okay, that's a bad thing. Let's hope they average out over the course of the year. If you ever wanted to look at self-funding, this is the level of data that you ultimately get over the course of time. So we want to make sure that you understand that there's a lot of extra work. Understanding how the plan works and some of the financial moving around, it's extra, but I would say for this client, it's probably worth it because just these two little boxes, which are tiny little snapshots of what's going on, there's probably $3 million worth of savings floating around in here. And this is just 1 year. So again, if this happens within your plan, fully insured, compounded year after year after year, creates a financial problem. I'm sure your CFO or your finance director their eyes would probably be going crossed seeing all that stuff going on. The last part of what we want to talk about, Awaken 180. I'm super excited about it. I did a quick little webinar with Paige back during 2021, I believe, just kind of offering this type of solution to the market, this and that. Well, we formalized it now and we're super excited about it. I actually think I'm going to do it because I like being healthy and eating healthy. And I think you'll see why once we get to a couple slides. But so these are from Paige and her team. So I mentioned I was going to reference that slide again. And so here it is. So 62% of people within your population, and this is the the study that Paige and her team did, actually might be looking for the same results as the weight loss drugs, but they don't think that they're a good opinion, whether they're not convinced on what the side effects may be, whatever the case may be. Um, they actually are looking for other solutions. And then this is the study that was referenced in one of the earlier articles. 85% of people who began using the GLP-1s stopped within 2 years. And a lot of times within that stopping, the weight was put back on because, again, I'm not a chemist, but it functions as an appetite suppressant. So, you hear the stories of, oh, I just don't think about food anymore. That's kind of how it ends up working. So with these two things here, it's like, okay, well, so if we're spending $1,300 a month for Wegovy or Ozempic, which is green, which is somewhere around $900 a month, we're spending $900 a month. Let's just call it 1,000 to make my numbers easy. You're on it for 2 years. So we're spending almost $25,000, and then most people stop using it, and some people put that weight back on. So when you go to back to that study that says, does this really outweigh, does the benefit outweigh the long-term solution? Well, if long-term people stop within 2 years, again, it's all hypothetical, but you can see how long-term, if habits and behaviors don't change along with it, if it's just kind of a quick fix to, I want to lose some weight and, I know that this is going to help me do that. I can see how that study might have a little bit more legs saying that it might not be a long-term solution. So obviously, and we know the impact that overweight and obesity can put on just you as an employer. I mean, these are all stats that are out there. This is the CDC, like just the contribution to chronic disease, which instantly hits your healthcare, um, and then productivity. We just know it leads to absenteeism, and so for us, we wanted to make sure that, okay, the healthcare carriers are providing means to get these GLP-1s. They were, doesn't sound like they are going to be anymore, maybe for 6 more months if you're Blue Cross Blue Shield. But what can we do? So Awaken 180, so for anyone who listens to the radio, a lot of patriots, ex-professional athletes have used Awaken 180 to lose weight. And so their mission is to inspire health and confidence through coaching, education, and support. Everyone deserves to feel healthy. When we feel good, we're happy. I can attest to that. Starvation and deprivation don't work. And you work too hard to lose the weight just to gain it back. And so that last line is referenced in all of the articles we've talked about what are the long-term effects, consequences, whatever word you want to put in there for these GLP-1s. You work too hard to gain it back. And so this is where Awaken 180's solution, natural approach, no medication. They try to restore your healthy body without caloric restrictions. This is the part I love, personalized one-on-one coaching. I thrive in that scenario. I might be different than everybody else, but I know if I have someone one-on-one, that can hold me accountable and that I can have access to, whether it be lifting weights, nutrition, whatever it is, I'm going to be infinitely more successful doing that. They provide 80% of the food on your program, which I actually didn't realize, but I know how much money I spend at Trader Joe's and all these grocery stores every month, so that's a good thing. Maintenance for life. And this is where we get into, we want to support our employees, we want to support them through their journey of being healthy. What is the more sustainable approach long term? And is it the GLP-1s, which are spiking? We know they work. It's not a function of do they work or not. We know they work. Long term, who knows? Based on everyone who started in 2021, most of them are off of it now. And again, I don't think you want to be on it forever at $900 a month. So, um, and what's the maintenance plan long term? I mean, you hear everything, and this is completely hearsay, so I don't want to say this like it's gospel, but it's causes all kinds of gut problems. You lose lean muscle, this and that. It should be accompanied by a nutritional program just like Awaken 180 and a weight regimen. Like I've heard all of those things, whether they're partially true, not true at all, whatever. But I think the point is we don't know. We don't know the long term with the Ozempics and the Wegovy's and all these GLP-1s. So this is something, not only is this something that we're super excited, the pricing's on the next page, so we're not gonna, the pricing, we actually had an email come in yesterday. Um, a 91-year-old employee, I'm sure, I'm not sure technically an employee or not, but 91-year-old, we sent this out to a client, our notice that we were rolling this out, and their 91-year-old employee wanted more information on it because he wanted to go through the program. Like, that's a super cool case study from like having this like, you know, 3 days old to what can it do for you? So let's not bury the lead. So for $1,000, you get 4 weeks of weight loss services. Typically, Paige and her team see people lose 5 to 20-ish pounds. 80% of your food, excuse me, is provided, weekly coaching, and then that long time, um, forever maintenance and support. And so this represents they were gracious enough to give us a 20% savings for members and spouses. But Paige has told stories where within this first program, that 4 weeks, they have helped type 2 diabetics get completely off of insulin with just nutritional coaching. So again, let's time out. Healthcare carriers say we will still do GLP-1s for people that have type 2 diabetes. It's going to be $1,000 a month for those GLP-1s average about $1,000 a month. In every one of their net operating losses, they blame the GLP-1s for all of it. So it's like, okay, you're spending all this money. Typically, people go on to those for a couple years, from what I understand. So it's like, let's just say you're spending 25 grand per employee for something that you're not sure what the long-term effects are going to be, and it's absolutely burying your health plan right now if you have a lot of people doing it. Or you can offer Awaken 180. Again, we know it's worked. We have testimonials from people that work. I think there's been I'm gonna butcher. I don't. We'll send out the stats on how many people they've helped. I've lost the number off the top of my head right now, but for $1,000, you get 4 weeks of this and lifetime maintenance. So when we're talking about, okay, if I have a company with 100 employees, how many people would just do this anyways because they like being healthy? Right. How many people might really need this? Well, how many people are type 2 diabetics that really need this? It's not a huge spend when you're thinking about for one person on Ozempic is costing you 25 grand. And then they have a bigger program. So if someone needs to lose a lot of weight, they have a 10-week program. Again, represents, a 20% savings where typical people there lose 25 to 40 plus pounds. And then Paige and her team have been great and said, you know what, if you guys just want to create your own packages, we'll do whatever you want, however it works for you as an individual employee, but we'll make sure you get 20% off the program no matter what. So we're going to start rolling this out immediately. I think we have a client that wants to do it right away for, again, um, if we go back to that GLP-1 Google slide of Google searches, I would say their employees are part of those Google searches. There are a lot of people going to them saying, we want this, we want this, we want to lose some weight, we're pre-diabetic. Well, like I mentioned, kind of everyone is pre-diabetic now, depending on, you know, it doesn't take much to be pre-diabetic, I guess. Let's just put it that way. And doctors are writing prescriptions for the weight loss drugs. If we go back to those slides where they stopped at 2023 on a curve that was going straight up, and then 2024 was reported they went up 250% from there. We know the prescriptions are getting written. So we want to make sure that this is a solution that we know has long-term staying power because they have long-term maintenance, support, and education. So we're super excited to offer this. We've talked to a couple clients about, well, how do we want to do it? Do we maybe want to pay for half of it and have the employee pay half? And if they hit their goal, we'll pick up the other half. So we end up picking up the whole thing. Like, there's all different kinds of ways you can do it. I mean, you can build this theoretically into working rates if you wanted to for employees, like depending on the company side who wanted to do it. There's all different kinds of ways you can roll this out, but we feel that it's a very active way to really dig into natural weight loss. And our carrier partners have maybe not this specific, but they have programs like this, kind of free of charge. And I'm not sure we've necessarily seen the results we wanted because the engagement hasn't been there. So, engagement is a big part of this, but um, if you have people that are type 2 diabetics, I think even just the first program, that weight maintenance program, that's that there are people that have had the success of totally coming off of insulin. And I think helping an employee get healthy naturally from that standpoint, it's a different type of offering as an employee benefit as, yeah, our healthcare carrier has, you can get reimbursed $150 for your gym membership. So I believe that was our last slide. We kind of wanted to end on that. So I want to make sure I didn't miss anything in the chat. Don't believe I did. Keely asked, so can employees still use their PFA money for prescriptions no longer covered by health insurance like Humira? So theoretically, the PFA, that can happen. So for anything, the PFA debit card, it's not going to work if you go to the grocery store and, try to buy a dozen eggs. But for anything that falls within a healthcare category, like the merchant code, theoretically, you can use it for that. Just know that if an employee tries using it for a non-covered medicine, it's not going to count towards their deductible. So that PFA card might not go as far as they want it to go. So just something to think about. And we can help through all that education with employees as well. So I did almost go to 10 o'clock. I was hoping to give everyone some time back, but hopefully this was helpful. We are going to get all of these slides out to everybody. If anyone needs those, the pharmacy notices, let us know, shoot us a note, email, LinkedIn, whatever. We'll make sure to get those pharmacy notices over to you. Any clients on the call, we have those notices ready to go. So you'll be getting those along with these slides as soon as we close out the webinar here. So at some point this afternoon, those will come through. And if there aren't any questions, thank you everyone so much for jumping on. I think most people stayed on the whole way, so we really appreciate it. If anyone has any follow-ups, we're here. And here's to a healthy beginning of the summer. Thanks, everyone.